And I'd also like to welcome Nancy Long, advanced practice provider at Vanderbilt as well, very adept at CAR T toxicity management and in outpatient settings, so they're calling you, not him, right?
That's right, that's right.
So, okay. Okay, so we're going to go through a couple of cases, and we'll try to focus on kind of broad topics. So first, we'll present case number 1. This will be more of a myeloid malignancy. So we have a 44-year-old Caucasian gentleman. He's has progressive fatigue. CBC shows a white count of 1.7, ANC of 400, hemoglobin 9.4, platelets 25,000. Bone marrow biopsy shows cellularity about 40 to 50% with 10% blasts. Dysplastic changes were noted. Interestingly, his FISH was normal, but NGS did show a RUNX1 mutation. So 44-year-old, kind of high-grade MDS. What do y'all think? Who wants to start? Dr. Yacoub, you want to go first?
Yeah, sure. Again, there's so much to discuss with this patient, but I would like to emphasize that a 44-year-old with a high-risk myeloid cancer, again, should be evaluated very early for an allogeneic stem cell transplantation. This should be like the destination therapy for him, and everything else we're going to discuss will be a bridge to that. So that should always be emphasized. And also, a 44-year-old with MDS is usually a concern, because MDS is usually a disease of patients who are much older than that. And for patients who are younger, we really need to kind of take a look at his personal history, family history. Is there other malignancies, other patients with hematologic malignancy, evaluate for any inherited cancer syndromes. So genetic counseling is definitely something we need to touch on somebody as young as this, especially if the donors will be from his family.
And
so,
can I ask you about that real quick before I introduce, to go on to the next topics, because this is something we've really started being kind of almost frightened with how often we're finding it when we start looking for it. And so do you guys, is there like a cutoff for age that you're sending for genetic counseling for these?
Yes, so 40 seems to be the age where patients stay with Fanconi and the inherited bone marrow failure syndromes. We like to test for them at 40, but then even our guidelines are pushing it to 50 now. So anybody with a blood cancer under age 50, we like to look into that.
And skin biopsies, I guess, right? Or usually, or sometimes swab for.
Yeah, it's getting a lot for now because of what you mentioned. It's becoming a specialty by itself. So again, I would definitely there's the testing for telomere on the peripheral blood and for DNA breakage and all that, but also genetic counseling, like referral to a genetic counselor.
And like you said, if their sibling potentially has the same problem, you don't want to pick them for a donor, potentially, right?
And there's now the DDX41, which is also very common, one of the germline cancer syndromes that we really are choosing donors with that knowledge to not be a family member too.
Okay, good. So now I'll let you continue, sorry.
Yeah, so there's been, it's become an entity by itself that we actually delegate to a genetic counselor early on in this part. So and that becomes a big thing in counseling about what to do next. And then for therapy, again, for the last 20 years, HMA, single agent, has been the only therapy that is approved and successful. There's now 3 of them, fortunately. So we have azacitidine and decitabine intravenously and the oral form of decitabine as approved agents for first-line MDS. So now we have 3. Each one of them is an option for this patient. They all have the same response rate in that sense, just different convenience. There's been so many trials. Everybody's heard about venetoclax in MDS. The phase 3 study is completed. The data is not published yet. It's very different from AML, different dosing, different. And we don't encourage people to start using that off-label yet. But again, that might be practice changing soon.
A lot at ASH about that this year.
Yeah, right? Correct. But again, it's very different. And if you ever use it off-label, you really need to read how it was delivered. It was not delivered the same way as AML. But that is coming soon. There's also the monoclonal antibodies, the immune therapy checkpoint inhibitors. All that is happening. So this might be a different answer next year. But this year is single agent HMA and early referral to transplant.
Okay. Would you say anything different?
No, I agree with everything Dr. Yacoub says, especially about being careful with the donor selection. In our transplant program, we are quite we don't actually have an age cutoff. We go by the biology type of mutations we see. We have a genetic clinic where we do routine skin biopsies during the pre-transplant workup, and especially when the allele frequency is high for any given particular mutation.
And go ahead.
Yeah. Now, as far as the treatment goes, our internal cutoff for transplant is less than 5% blast. There is very weak data to show that, but however, we like to have the blast clearance before we accept the patient for transplant, or at least start conditioning chemotherapy. So we have been very lucky with combining venetoclax and HMA to get a deep response very quickly in these patients and take them to transplant. And we have used it in our practice off-label quite frequently, and thankfully insurance is not giving us that much trouble to get venetoclax off-label, but I agree we have to wait for the results of the phase.
And that actually is a very common practice in the US. Actually, like the statistics are almost 50-50 people using venetoclax upfront, off-label.
So just so we can help our people listening, so if you were to use it, I think we can talk about, like, how would you dose it for, like, 2 weeks on, 2 weeks off?
Yeah, it's generally 2 weeks on, 2 weeks off. Again, one thing we need to be careful here is risk of infections and severe cytopenia in MDS patients. See, the MDS patients are inherently different than AML because they have underlying marrow is damaged compared to AML. AML, you give 7 and 3, you clean out the marrow, you have normal hematopoiesis bounce back. In MDS, you give chemotherapy, venetoclax, HMA, the blast goes down, but the native marrow is still damaged, stem cell disease. So these patients will not recover their counts, and many times you see trouble with bleeding, and lots of infections. So having the triple prophylaxis with antibiotics, antifungal, antiviral, those adjustments appropriately, 2 weeks on, 1 week off. But we have even a few patients who are like just taking 1 week of venetoclax a month and still maintaining the disease response. So it really depends. I generally don't like to dose reduction for the first 1 or 2 rounds of chemotherapy. I at least want to see, make sure that the blasts are responding, and then kind of titrate the therapy based on the toxicity profile and the time to transplant, of course.
And usually, just to make sure everyone knows, if you're on fluconazole, you cut it in half and posaconazole even more for the venetoclax.
Yeah, it's 200 milligrams for fluke and 100 milligrams for posa.
Right.
Yeah, Cresemba also 200.
An excellent discussion is the safety and risk, because at the same token, if you get a neutropenic infection, and it might delay the transplant or obviate the transplant altogether. So that becomes a calculated risk there with that.
And officially, I mean, some of the early studies showed you can go straight to transplant without therapy, but you like to get them less than 5% blast.
Yeah, I think, I agree with those studies, but the transplanters, we are burned by the cases where patients had progression before engraftment. Like week 2, you're already seeing the circulating blast, you have graft issues, especially in some of the high-risk patients. When you give ATG, you remove that immune check on the patient, and with the conditioning chemotherapy in ATG, and then the disease progressed to AML very quickly. So we like to have some blast control of the blast so that at least you have graft has time to take in and that start that graft versus disease effect for at least a month or 3. It takes roughly 3 months for graft to mature in the patient. So
I agree.
You want to make sure your patients don't progress in the meantime.
Yeah, agreed, yes. Okay, so this specific patient was treated with azacitidine, but unfortunately, when they rechecked a marrow, ended up having 50% blasts. So what would you do now?
Yeah, so again, unfortunately, even in anybody's hands, HMA has a 20% objective CR and 40% objective response. So the majority will not respond, unfortunately, just like this patient. This is actually not uncommon that this is the outcome. Now, this patient has acute myeloid leukemia. And as we think of acute myeloid leukemia, it's not really one basket. You have this guy who progressed from MDS. You have the 20-year-olds who had a CBC that is normal a month ago and now has this acute leukemia, very different diseases, and also the 80-year-old who's acute leukemia. So again, they're different subjects, different patients. So induction therapy is a standard of care. We're fortunate to have CPX-351 approved in patients with treatment-related MDS or treatment-related AML or AML secondary with MDS changes, although the study included older patients than this patient. There's also standard induction therapy with 7+3. And there's also the data for HMA venetoclax, although patients who were treated after HMA failure did very poorly, with their CR rates for under 10%. So none of those great options are great, but the standard of care might be induction therapy with a combination.
And then to add on to that, to either of you, so if they would have presented this way the first time, like 2 months before, would you have done HMA venetoclax or just regular induction? Or, I mean, I guess it would be considered an MRC-associated.
Correct.
AML.
So that's really why in this morphologic classification of 10% or 20% AML is so maybe out of touch now with the biology of diseases. But if he presented with a 50% blast, we would have called him AML, right? He would have had AML therapy, and maybe the dysplastic changes would have been dismissed or not even paid attention to. But he would still be, probably will see some dysplastic changes.
Yeah, I completely agree with that, and especially with the comment that the 20% is completely arbitrary. And there was a nice editorial in Blood Journal recently by our esteemed colleague from MD Anderson that if you look at the historical outcome of MDS EB2 and AML, they're same, basically. Biologically, they're the same disease. Even from the transplanter side, the outcome of patients with a blast anywhere between 10% to 100% is really the same. It's more of a genetic makeup biology, and the response to therapy determines how your patient is going to do. So hopefully there are some changes coming in WHO classification in near future.
Because you get that report from the pathologist, like 18% blast, and you're like, come on, just give me 2 more %.
And I think it creates a lot of challenges, especially for the study. If you have, and that's why many of the IITs, which are written now by the investigators, they have this broad inclusion-exclusion, which allows anywhere between 10% and above. But still, majority of the industry-sponsored studies has this arbitrary cutoff of 20%. And you have a 20%, and you do the screening marrow, and it's like 15%. And patients screen fail.
And for everyone, for Vyxeos specifically, it says like myelodysplastic-related change is AML. So I mean that's the way and it is an expensive
Currently
drug.
labeled,
So
yeah.
I mean, but there is a specific indication for it. So.
Correct.
Okay, so this patient was given Vyxeos, and after a month, he had a repeat bone marrow biopsy. There were less than 5% blasts present, but when they redid an NGS panel, whatever that significance of it was, there was still a RUNX1 mutation. So what do you do now?
So RUNX1 is not one of the germline genes. It's usually acquired, so it's a marker of the disease. So this patient has MRD, basically, and he meets criteria for remission, just has MRD. And that opens another kind of data regarding what you do with MRD positive AML for transplant. What can you do to eradicate the MRD? Is there actually a tool to do that? And that becomes a higher complexity decision versus transplant with this morphology, with this disease. But unfortunately, this is the tools we have, and they might not be able to eradicate MRD.
So we call them remission, but we know there's something there still.
Correct.
Exactly. And then I guess in certain situations, if you have targeted therapy for other types of leukemia, you want to get them MRD negative before transplant, but in this situation, you do your best.
If you have luxury to do that. Now, especially if this patient already have a donor ready, he's a 44-year-old eligible for myeloablative conditioning, I would take this patient to transplant with the understanding that he's at extremely high risk for relapse. So having a preemptive post-transplant maintenance therapy with HMA or something, or kind of preemptive DLI strategy is the way to go.
And you can follow that after, right, as a MRD kind of after transplant, maybe?
So not many centers actually have the NGS-based MRD. Like, see, the NGS here is just a next-gen sequencing. It doesn't go down deep enough. You need to do error-corrected next-generation sequencing, and that test is not commercially available at most of the centers. So we do flow MRD at our centers, which is good, but it's not good enough. So.
Perfect. Thank you, guys. That was good. Good discussion. Okay, so now we'll get to diffuse large B-cell. So we have a 69-year-old African-American gentleman. He presented with an enlarged neck mass. The biopsy revealed diffuse large B-cell lymphoma. Looking at the phenotype, it was CD20 positive, CD19 positive, 10 negative, BCL6 negative. The Ki67 was 80%. On PET, he had stage 3 disease. His LDH was 600. We can talk a little bit about the implications of all that for a diagnostic and how you would approach this patient now, and the risk for relapse. But he got 6 cycles of R-CHOP with a complete response. So you want to talk a little bit about his phenotype and?
Yeah. So a lot has been done and said about different subspecies of DLBCL, right? Activated B-cell, ABC type, germs, GCB, and something in between. Okay, this original data came from NIH based on gene expression profiling, and then subsequently we have adapted based on IHC markers, trying to come up with kind of poor man's way of classifying the patients based on CD10 presence and BCL6 presence, whether they will fall into category of activated B-cell ABC or GCB category. So in these patients with CD10 being negative will fall into the and BCL6 negative will fall into category of ABC subtype of diffuse large B-cell lymphoma, which is traditionally known to have poor response to R-CHOP and higher frequency of relapse compared to GCB subtype of DLBCL. However, I want to emphasize here is that Hans algorithm is not perfect, and you will misclassify roughly around 20% of the patients. If you want to accurately know what subtype of DLBCL you have, you need to do gene expression profiling from lymphochip, which is a commercially available assay, which is rarely done at most centers. And the reason is we rarely pick treatment, at least in a newly diagnosed setting, based on whether you have a GCB or ABC.
Right. And so this one is an ABC type, and just rough numbers, if you really do the gene expression profiling, it's like 75% relapse for GCB versus 50 for ABC, roughly. Is that,
Yeah, I think the long term.
A big difference.
Yeah, big difference. There's certainly a big difference.
And so what you were talking about is using like the Hans algorithm, which everybody can get. And I guess one of my questions is, there is some data for like Revlimid and R-CHOP in the upfront setting. There were several studies that looked at that, and we think that maybe Revlimid might hit ABC type more preferentially, maybe. So do you have any like strong feelings? Because I know there was mixed results from those studies.
Yeah, the phase 2 study was positive, the ECOG trial, and then the robust trial, which was a phase 3 multi-center. It was an international study, was unfortunately did not meet the primary endpoint. And that proves a point, actually, that we are really not good at finding the exact subgroup of DLBCL where these targeted therapies will work. And it actually applies to all R-CHOP plus type of phase 3 studies. So R-CHOP plus Revlimid, R-CHOP plus Velcade, R-CHOP plus Abrutinib, all large phase 3 studies negative. Okay. And the problem I see, and then all of these studies have, of course, the subgroup analysis, the exploratory analysis has been done, and there is a signal that it might benefit some of the patients. And different studies, depending on where you look in Revlimid study, or if you are older, it doesn't help. If you're younger, it helps. Abrutinib studies, if you're younger, it helps. Older, you don't help. Based on IPI, the low IPI, it doesn't help. High IPI, it helps. So, however, that's all caveats of subgroup analysis, but the study were negative studies. And the problem I see with this trial design is that most of these studies they've used a different criteria for classifying ABC and non-GCB subtypes. Some of them has used the lymphochip, some of them has used a centralized IHC testing, and average time from the diagnosis to the start of treatment was roughly 4 weeks in all of these studies. So these patients, if you look at the control arm of robust trial or Phoenix trial, which compared the R-CHOP plus Imbruvica or Abrutinib, the control R-CHOP, the PFS was actually 70%, which you don't see in ABC subtypes of DLBCL. And that tells you that there was an enrollment bias of all of these phase 3 studies. These patients were better risk for whatever reason, and most important reason in my opinion is it took them roughly a month to randomize these patients. If you see a high-grade lymphoma patient and you need to start chemotherapy yesterday, that patient was not going on that trial. And that might be the reason the study failed to meet the primary event-free survival despite adding this novel drug. But so my point is, yes, there might be a subgroup of patients with DLBCL who will benefit from adding an additional novel therapy, whether it's Imbruvica or Revlimid, but we haven't proven that beyond doubt yet.
We have, right now we have a study from MorphoSys. It's tafasitamab, lenalidomide, R-CHOP versus R-CHOP phase 3 open, and it's like 30 days to get them on, which is tough, but I understand why.
And I think in 2 years from now, we'll have a R-CHOP plus mosunetuzumab study, and I'm worried that it will, hopefully it will be a positive study, but that's a problem with all high-grade lymphoma studies. Where it does not clearly represent what we see in the community.
I have more questions, but I'm just going to go on. So.
By the way, the polatuzumab study was positive.
I know, that's what I was going to ask. Okay, go ahead. Polatuzumab, go ahead.
So
polatuzumab, R-CHOP versus R-CHOP was at ASH.
Yeah, so they switched the vincristine with polatuzumab, of course. And so our CHP with pola versus R-CHOP, and it was a very nice study done, and the study was agnostic of ABC or GCB. Any high-risk patients was eligible to go on this study, and study met the primary endpoint, which was event-free survival. There was a 6.5% improvement in patients who received pola CHP over R-CHOP. And I think that's a real difference. However, there was no overall survival difference, which I believe is because R-CHOP group did actually better compared to historical standards. And many of the patients who relapsed on R-CHOP arm did respond to subsequent line of therapy. Because we are getting better and better at treating relapsed refractory DLBCL, like I presented the data in my talk earlier, it's hard to prove the overall survival difference in this upfront setting. But in my opinion, I think 6.5% is a still meaningful difference, because what we know is that once patients with DLBCL relapse after frontline therapy, many of them will not make it to the second-line therapy, CAR-T or stem cell transplant. So in my opinion, you should use your best therapy up front.
So you would use it?
If it get FDA approved.
So 9 months later, the patient relapsed, not unsurprising. So we'll just kind of move forward a little bit. But I guess in this situation, right now, you talked about CAR-T, and we can't do it second line, but I mean, if it was approved, you would do auto transplant, I'm assuming now, if the patient was chemosensitive?
Yes, sir.
And if CAR-T comes along, so in this specific patient, he did receive ICE chemotherapy and obtained with Rituxan and CR2, and then went to autologous stem cell transplant with beam conditioning, and then 3 years later, at age 73, he relapsed. So what would you do now?
Okay. I'll let Nancy answer.
Yeah, I'm so sorry. Yeah, I really want to.
I would advocate for CAR here. While he's been heavily pretreated, he's 73, we involve our geriatric team, make sure he has satisfactory organ function testing, as well as KPS. And like Dr. Dholaria mentioned, we can manage these patients outpatient. We can use our skill set with the acute toxicities during the first 2 weeks of CRS and neurotoxicity, and then manage them in our long-term clinic. Okay,
so when you're managing these patients, he's going to be 73. So are y'all talking to, they're coming into the clinic every day for an assessment, or you're talking?
For the first 2 weeks, they will come in every day after infusion.
And you're watching for any signs, like what
any signs of CRS, so fever is usually our first sign that we're going to have cytokine release syndrome. We also have employed remote monitoring now, so we can use telehealth and then overnight monitoring, so we have their vital signs 24 hours a day.
Like on
they're wearable devices.
Great, yeah. Oh, that's wonderful. So you can see if their heart rate goes up in the middle of the night.
Exactly, and we have a nocturnist team that's devoted to doing the telehealth at 10 p.m. and 6 a.m.
Wow, because so usually the fever precedes more aggressive symptoms, usually?
Usually. We also see hypotension, hypoxia as well for CRS, and then the ICANS or neurotox comes a little bit later typically.
So for everyone else, the cytokine release syndrome, CRS, is whenever the T cells are doing what they're supposed to, fighting their target, but then causing an inflammatory
Huge
reaction.
inflammatory response, yeah.
And so we want to catch it early because those patients, especially the older ones, could get really sick.
Right, and now we do use Profi-Dex during lymphodepletion chemo too, so we've seen that helpful with our CRS.
And for the neuro, do y'all do a different assessment, especially for the older patients, trying to assess them because it's a little bit different than the straight?
Well, we do involve, like I said, our geriatric team, so we make sure we know their cognitive baseline prior to going into CAR, because sometimes they might have a baseline tremor or things like that that we want to be aware of.
And you've seen it sometimes where they just like space out. They just don't, like, it's an interesting neuro.
Yeah, we've had patients wander to other parts of the hospital and not remember. So, for sure.
So, and so you feel safe that, like, we can do these patients 75, 80. I mean, you're managing these patients better than auto, you think?
Yeah, I think so. And like Dr. Dholaria said, our oldest, I think, at Vanderbilt was 86 when we did CAR, and now she's 88 in remission.
That's wonderful. All right, so we did 2 of the 3 cases. Sorry, you don't get to see the third one. But I want to thank you guys so much. This was a wonderful discussion, and thank you guys for coming here to talk. I really appreciate it.
Thank you very much.